So I thought it might be good if you guys introduced yourselves and gave me because, like, honestly, both of you have such extensive careers that I just thought it might be good for you to summarize them in the way you want them to be
Sure.
summarized. So, Marlene, go ahead.
Oh, great. I'm Marlene Smadu. I am a retired registered nurse. I was licensed for probably 45 years. I'm no longer licensed as a registered nurse, but I teach part-time at the Johnson Sherman Graduate School of Public Policy at U of R. With Dan, I teach the Excellence in Healthcare Leadership course, which is
Okay.
offered online. It is a fantastic experience. I wasn't looking for any work. I told Dan this all the time, but when I saw the curriculum, which he was very instrumental in constructing, I said, I can't resist. It's exactly what I think healthcare leaders need.
Mm,
And I think that the response from our participants is the same. It's what they need. I've practiced nursing in all domains. So we talk about clinical, administration, education, research, and policy. Did work 4 years with the provincial government. And I've worked in 3 countries, Canada mostly. I worked in Papua New Guinea very early in my career, and in Qatar as part of a administrative leave I was having. I worked there in developing a new nursing education program for 6 months. So that's a thumbnail sketch.
yeah, and you were in the ministry for a while too, right? Were you deputy minister, assistant deputy minister?
I was assistant deputy minister and principal nursing advisor for 4 years.
Yes.
Yeah.
So, Dan, I don't know if you know this story. I've told Marlene this a few times, but when I was a nursing student, I was doing a practicum at the Kinsman Children's Center.
Oh, right.
And the director had a meeting in Regina, and she was like, you should come with me and go to a meeting at the Ministry of Health. And I was like, okay. Like, honestly, like I was, whatever, 20 years old, like no money, no experience, like nothing. So we flew to Regina and we got in a limo to go from the airport because they said, well, there's 5 of us or something. So it's cheaper to get a limo to take us all. I'm like, okay. So we got into this limo and then we went there. We had this meeting and Marlene, I don't know if she was in the meeting or I met her somewhere else or whatever. But a couple weeks later, I get a note in the mail of Marlene saying, it was nice to meet you. Good luck with your nursing career. I know you'll do good things, like whatever, whatever. And I still have that note in my little like memory keepsake box.
Aw, cute.
Yeah.
Good.
So, I mean, when you're talking about nursing leaders, she is gold standard.
Oh,
Thank you.
absolutely.
Okay, Dan, now your turn. See if you can beat that.
Well, I can beat it because I get to work with Marlene every week.
Thanks.
Yeah.
So as a fellow executive in residence, we get to co-teach, co-instruct, co-lead the Excellence in Health Leadership program. That is an online program that it just feels like almost therapy, recovery from a healthcare system, but also a bit of a sense of continuous contribution. We still, I think, have something to share, and I'm learning every day from Marlene.
Yeah.
So, we start out. You have these stories, and I have lots of stories in my early career of bumping into people who are shining lights and who are mentors. Marlene's my mentor. Hard to believe, a bald-haired, a washed-up deputy minister, but Marlene was my inspiration. Yeah,
Right.
99. Do you remember going to Ottawa?
Yeah.
Presenting?
We were presenting for the Canadian Medical Association and both thinking, are we going to get like daggers thrown at us?
Yeah, I was great.
We were well accepted.
Absolutely. So
In 1999, you guys presented together?
we did.
What were you presenting on in 1999?
Magnet Environment, Magnet Hospitals. So
okay.
Dan was the only, well, he was the first, but the only CEO in 1998, 99 who agreed to participate. We had some money at the Ministry of Health to implement high quality healthcare workplaces.
Okay.
With some of the SRNA staff were supporting it. Karen Eisler was actually kind of leading it, but we allocated, it was like $150,000. It was really nothing. But we said we wanted to try some things that were related to magnet environments and creating high quality healthcare workplaces. None of the other CEOs came forward, and Dad said, I'll try. I said, you know what you're getting into? I'll try. It's worth it.
awesome.
It was an amazing opportunity. And then it became a huge program after that. But he was the only one that came forward. But
Tomorrow, I'm releasing just a short little podcast about what I've learned over the last 3 months. So every quarter, I'm going to do a little reflection and learning on all the interviews. And the first learning or the biggest learning that came out of the last 3 months is the power of yes. and just saying yes and trying something and taking risks, because every podcast episode had something around like the energy it creates, the motivation, the connections, like the let's try it, like really can mobilize people, as opposed to a culture of no, we can't do this. So it's good, like it's already coming up again in this one.
Yeah.
Yeah.
No, it's
For
great.
sure.
Okay, so I wanted to speak to you both because of your extensive leadership experience and because you're teaching leadership. So you are really deep into this topic and probably reflecting on your own careers and the leadership you've seen, the leadership you've been a part of. And I really feel like there's a bit of a crossroads in the healthcare system right now in terms of maybe a recognition that the old ways of doing or the old ways of being or the way we set up the healthcare system 75 years ago is like not maybe working so well. And then there's this pressure to like reimagine and redesign and figure out what that future looks like. And that's going to take a lot of leadership. And I don't envy leaders at all for the position that they're in. It must be the hardest job in the world when you're leading in a space that has so many real world consequences, like life and death decisions. And, you know, and I know everybody's doing the best that they can with what they know and what they have. And so I just thought we'd just have like a conversation about what do you think the leadership skills are of the future? How are we going to usher in this new era? What is that going to look like from not only formal leaders, but informal leaders at every level? And just have a kind of a wide ranging conversation wherever you guys want to take it. So when you think back to leadership in the 80s or 90s, what are your memories of that time?
Well, I came up, my first nursing education program was at the Regina Greynuns Hospital School of Nursing. So if you want to talk about the origins of the Canadian healthcare system and sort of military, church related, hierarchical, you know, that was all there. But there was a huge relational piece to everything that went on in that hospital, both when I was a student and when I was practicing there. The values that they espoused were, you know, really very clearly enacted, but very much top-down management and lots of management. I always say to the nursing students that I was working on a very large unit with one ABC. It was, you know, psychiatry, female orthopedics, iron, nose, and throat. Like, it was just this hodgepodge. It was like a rural hospital. Lots of patients. We had a big medical unit there. But I had a head nurse, an assistant head nurse, and a team leader who made me successful. Like, they made sure that I wasn't going to make a mistake. I'm not suggesting that that's the right model, but it worked because of the values and the kind of expectations and relationships that occurred in that. I think that early on in healthcare management, I would say it's still happening to some extent, but the idea is if we can maintain the status quo, if we can keep things running, we are doing a good job. And I'm not sure that even in the 80s that was appropriate. I mean, some things were kept running, but it's absolutely not appropriate now. So it's interesting when you talked about redesigning the healthcare system. With Dan's help, I'm leading the Masters of Health Administration spring seminar in June, and I got to pick the theme. That was actually why I agreed to do it. I said, if I can do this, I'll do it. And it was challenge the process, redesigning the Canadian healthcare system. And the challenge the process is coming from the Kouzes and Posner attributes of exemplary leadership. I've used that model for myself for years. Sometimes I focused on other aspects of that model. You know, I know for a while in my career, I was really focusing on that, you know, celebrate successes, because I thought we'd really missed out on that in many aspects, especially when I was in the Ministry of Health. But I'd say in the last 10 years, and I'm haven't been fully employed in the last 10 years, but I'm as a member of the public, I've really focused on challenge the process. I don't think you can be a leader in the Canadian healthcare system now to be effective if you are not prepared to challenge the process. I think you need to look at the patriarchy, the colonial structures, the misogyny. It's just so many pieces of our society that are reflected in the Canadian healthcare system. And if we're not willing to challenge that, we're not meeting the needs of our patients, families, residents, and clients. We're also not meeting the needs of our workforce. And that's where I think, when you think about what do the leaders have to do, it's different. It's actually the phrase I use, if it's not broke, break it. Like if you're still doing something that you were doing 25 years ago in the health system, you need to break it and start over because it's not going to work. And it's not, maybe it's working for you, but it's not working for the system.
So there was a huge insight we got. Actually, Marlene and I were together. We went on a Best of Britain where we looked at high performing organizations. And it's kind of this opportunity with an outside set of eyes to look at a system that's, historically highly bureaucratic and has its elements. But so we were talking to some of the quality gurus, Helen Bevan and Kurt, and one said they were talking about what failed. And this is something that didn't exist in the 80s, but started to emerge in the 2000s is humility. Like the humility to say, boy, that didn't work. But this spirit of fail forward fast, which, you pick yourself up, you dust yourself off, and in a persistent way, we said yes, we'd do it, and it didn't work. But we're going to try something else. So they said what wasn't working for us is we failed to address for the team members what's in it for them. And this is a hard question. I don't know if it's hard culturally because we're Canadian or what the deal is. But if someone were to ask you, Kyla, what's in it for you, you'd come up blank, potentially. And they said we had to reframe the question. And we reframed it by asking, what does a great day look like? So inspired by this, years later, I was in Saskatchewan. I thought, we keep on telling the physicians, and in this case, it was family physicians, that we've got this great thing for you. It's called primary care. It's team-based care. Here it is. Here's the design. Here's the graphs and the pictures. And the physicians would have a blank look on their face. And we keep on asking them, what do you want? And they'd say, nothing. So we stopped and asked them, what does a great day look like? And I can recall this like it was yesterday. There were probably 10 or so family physicians around a table. And the first few that responded by answering the question with, I don't know. I thought, whoa. So we keep on coming here to try and rescue, to think that, as administrators or as leaders, we've got the greatest of ideas. But we haven't even addressed the fact that we have a couple of physicians, at least around this room, that can't describe what a great day looks like. Now, as we get into it, what started to emerge as an answer to that question were all of those barriers, those niggling, maybe they were pebbles in the shoe, but those niggling things that were in their way from today being a great day. Turns out 95% of what they raised wasn't about them. It was about the patients that they were really struggling to treat. It was about the fact that episodic care was being outstripped by chronic disease, that mental health and addictions and chronic illness and complex care was really tough to deliver in the current context of fee-for-service, and time was the enemy. Anyway, I could go into it, but the key is how we frame it. And that taught me that in the 80s, Marlene said stability. A lot of it was designed around command and control, and there's still remnants of that. It was a militaristic structure. It was a religious structure. We came from our history to be, kind of as in who's in command, who's in control. And what we found is that, you enter into this and you watch the people in charge for decades before, and they were dealing with a very static system that you could get away with that.
Yeah.
They were very much command and control. They were bulletproof in terms of anyone thinking they didn't know what they were doing. And we found that was a failed approach. What it took was humility, curiosity, and all of those preconditions for learning.
Yeah, the two loops model, the Berkana two loops model, I use a lot about systems that are no longer fit for purpose and new systems that are emerging. And there's a really strong role in the dominant system of stabilizing it and holding on to it and keeping it static, even as the system is becoming less and less fit for purpose. they're just holding on to it because it's what they know, it's what they're comfortable with. And so the idea now is, how do you, yes, stabilize what needs to be stabilized, but then also sort of generate the energy and the change that you need to create the new system that's more fit for purpose.
The metaphor that we've been using is a
Mm-hmm.
controlled burn.
Okay.
You can wait, and there is a finite kind of trajectory for any organization. You take it long enough, and this organization is going to fail. If you allow it to just sustain and build up, it's almost like old growth in a forest.
Yeah.
It's going to go through that natural progression and life cycle. What we do is we can't risk in a 24/7 system that's continually providing care and service. We can't risk destroying or blowing the whole thing up.
Yeah.
What we do, in Marlene's words, if it ain't broke, break it, is we do the breaking like a controlled burn.
Mm-hmm.
We mitigate our risk by picking an area and going in there hard. And then we pick another area. And eventually we disrupt everything. But we can't just light the proverbial match and let the whole thing go ablaze. So if we're not agitating, if we're not doing a controlled burn, then we're not really being as thoughtful as we need to be about the future. So it's small tests of change, continual experimentation.
So Marlene, what are the skills that you're trying to build in leaders to challenge the process?
And I'll just start my comments by talking about what both you and Dan have talked about, is that, you know, we tend to talk about leaders who are in formal positions, and in a system as large as the health system, you know, I don't know if we're 40 or 50,000 people now, like, we actually need to support the leadership at all of those levels. That's one of the key messages that we give within our program. You know, we have people who are in formal positions, but it's the licensed practical nurse who's working on a surgical unit at the Regina General Hospital who has a leadership opportunity and needs to be supported in that leadership. So the controlled burns, and I love that metaphor, can happen at a variety of levels. We saw that with all of our QI work, right? It was like, get people data that has meaning to them at their level, and then let them figure out how they would do things differently in order to make sure that that is effective, or whatever the process is good for the patients, families, residents, clients, and themselves. So I think that the leadership attributes, and the reason I've picked on challenge the process, is that's often the scariest part, is to say, you know, I came into this system as, I don't know, like a 22-year-old, but most people don't come in as a CEO. But anyway, and they've always done it this way, and you know, therefore, like, even though I think it might be better if we did it another way, like, do I have the support? Do I have the backing? Can I fail and people will still have my back? That kind of thing. So Kouzes and Posner talk about seeking out opportunities and looking for opportunities for innovation without blowing up the whole system. And it's whatever level that you're at, you know, be able to have an environment that's comfortable enough, and you need to be supported by others to be able to try those things. And when I teach this to nursing students as well, like, when you start to say to them, you know, the nurse that's worked on a neurosurgery unit for 12 years, and, you know, she's an expert, and the care is, you know, pretty easy to unfold each day, and, you know, she manages all of her responsibilities, and say to her, like, why don't you volunteer to be on a committee that's perhaps looking at, I don't know, the integration of AI into patient teaching tools or something like that. Like, those opportunities get people thinking bigger than what their particular role is. If we could energize 40,000 people at whatever level they're at to be able to think about how things could be, I mean, QI, we talk about how can you improve the system every day, but how things could be different. You know, we would come up with that. It's kind of incremental, but it actually becomes, it's like an amoeba joining with another one. Like, pretty soon it becomes this big mass of thinking differently and being more open to change. I think our leaders, I would say one of the biggest frustrations, Dan, you can check me on this, but the people that are in our program, is when they are stopped from implementing something that they know they have to do. And you can say, well, why are they stopped? it's often some kind of an edict that comes from someplace well above them and they have no idea where it's coming from. Or it's a removal of resources. So, we were moving along on this particular piece and then now there's no budget for it. So, got to figure out how to do it on the side of their desk. So we have lots of challenges with a huge organization like the healthcare system. And traditionally, we've acted as if you reorganize, you change the organizational structure, that you're actually going to help make things better. And it's exactly the opposite.
Yeah.
That's not where we need to invest time. It wouldn't matter. I mean, it does matter what the structure is. I know there's great research on that, but please don't change the structure one more time thinking that now you're going to get these amazing results out of cancer care or whatever it is. That's not where it happens. It happens here, and it needs to be supported and it needs to be led. And I think, and we just talked about this yesterday in class, so Dan, you can add to it, but many people in our system, including the leaders, have no idea what the system looks like.
Right.
They don't even see it as a system.
Yeah.
And if you're going to try to lead through just looking at isolated pieces, you are failing everybody. You're certainly failing the patient who's going through the system. You're failing the people who work in it.
It's interesting, Marlene, because one of the things that we've noticed throughout the years, and you and I have talked about this, is historically it took a leader to become ill themselves or to have a family member close to them who have to experience the system.
Yeah.
They come back with religion. Like it's like insight. Oh my God. I had no idea. Like I can talk about the silos, but boy, the journey, that's a different matter. This thing is strung together or not, right? To deliver an experience, a journey that is fundamentally broken. And that's some of the challenge here. A lot of where we start with quality improvement is on point improvement, but we've got to move on to higher levels, right? So I guess what it comes down to in leadership is that ability to zoom in right to the unit level and zoom out to be able to see the myriad of players that are necessary to team together to be able to tackle wicked problems. So, we started out by talking about finite and infinite. There's no doubt the game is infinite, but the structures are finite. The approaches are finite.
Yeah.
In fact, we want to disrupt those. So I want to take you back because this is an important kind of point in time, and that it involves Marlene and I. This is where Dan had a huge aha moment, and Marlene was there. It was her initiative around magnet hospitals. Do you remember, and you can describe this so well, Marlene, the surprise and kind of the nervousness that we had around creating just a small fund for the staff to innovate?
Yeah, and that was part of this funding from the Ministry of Health. But people thought that if we gave this small amount of money to the nurses around their workplace, that they would buy things for themselves. That they would fix up the coffee room or get a new coffee machine or, to make their work environment better. And every one of the suggestions that came back had to do with providing better patient care.
Yeah, of course.
Getting a Broda chair, getting IV poles and commodes that would actually fit in the bathrooms. And Dan, your explanation was those were things that never hit your radar because they didn't ever hit the capital budget, right?
Yeah.
They were too small. They were so small, and yet they were instrumental in making the work life of those nurses and the care of those patients better. And so they did. They bought IV poles that had 4 legs instead of 3, and they got
So they didn't tip.
Yeah, the commode chairs and this Broda chair.
Brakes on beds.
Brakes on beds.
I never knew.
Yeah.
Like I'm in the nosebleed section, even though it's one hospital or one health region, right? But they knew that these were barriers to a great day.
Yeah.
These were pebbles in their shoes, but they added up, to big things.
I had a friend who was in palliative care on the medicine unit I used to work at, and I was deep into quality improvement at that time. And I said to him, I'm like, okay, you've been spending lots of time in hospital. What's one thing you would change? And like he was literally within a week of passing away. And he said, I would like someone to get some WD-40 and go and put it on all the wheels of every bed and every wheelchair in this hospital, because all I hear all day long is squeaking wheels. Again, like, would you ever think of that? You know, like it's just the small things. And I had my 25th nursing reunion this fall, and so many of my friends are still frontline
Yeah.
direct care providers. I talked to lots of them separately. And the general theme was, I don't know if I can do this much longer, because there was this sense across a lot of people that we used to be able to make change. We used to be able to decide things. We used to be able to make decisions that were the best interests of our patients. And now we have no choice, and things are being done to us and for us. You could sense a real sense of defeat. They're like, I've been trying for 25 years and it's like worse than ever.
So Kyla, that worse than ever, I just want to flag that. There has been a deterioration, and COVID played a very big role.
Yes.
What happened is we went to emergency management type approaches, which are by their definition command and control. And you can do that for a week or two. You could possibly do it for a month, but don't do it for 4 or 5 years.
Yeah.
Because what you do is you're changing the culture. We reverted back to old approaches. We also learned some very bad lessons around the episodic needs of the population. Yeah, we needed to be better prepared. Yes, we needed to respond in that way, but it all shifted back to we need more beds. We need more acute care. We need more institutions. And we really need to break free of this thinking where we can really look at home-based, community-based alternatives, look upstream, look at complexity, look at chronic disease. Ultimately, this system, it seems to take on a life of its own, but it also creates some of the problems that we're encountering. So if you take someone frail and elderly, and the only crisis response we have for them is the emergency department, within hours we start to see that decline. And if they didn't need long-term care coming in, they'll need it going out. Now, for the staff that are working in these various units, from where they sit, they see ALC patients, they see people in beds and stretchers. Their immediate thought is, we need more beds. We need urgent care centers. We need beds. Well, if we don't get upstream of this, we're never going to come up with a system that avoids the crisis in the first place.
I sent you guys a video. I'll put it in the show notes too, that Simon Sinek video where he talks about finite and infinite games, and that a finite game is like a game of baseball. Like, everybody knows what they're playing. Everybody knows what they're doing. Everybody knows the rules. The objective is to win. The objective is to finish the game, as opposed to an infinite game, which is about keeping the play going, about sustainability. As the players change, as the conditions change, you're playing the long game for sustainability. And if everybody's playing a finite game, there's balance and stability. If everybody's playing the infinite game, there's balance and stability. It's when you put finite players or thinkers into an infinite game, and there's this pressure to succeed, to win, and this comes with election cycles as well. Like, what can we get before we put out the next campaign brochure? How do we win this aspect of wait times? Or, but you have this system that's actually playing this long game of relational care and sustainability of the system. And I feel like there is a tension there that is not being talked about. And people are getting really unmotivated by the finite games that are being played with the healthcare system instead of the long-term thinking that's required. Marlene, do you have any thoughts on that?
I absolutely agree with you. We actually use the finite infinite games in some of our work with the Razor community that I am part of with my daughter, and because it is about when you are going to collaborate over things like gender equity or domestic violence or whatever. Those are some of the things that we're interested in. You are in it for the relational piece, and you look at other organizations that bring, kind of different strengths and different pieces so that you are collectively going to be able to start to make some progress. Dan and I teach wicked problems in the program,
Yeah.
and it's an example of a wicked problem. Like it's morphing and changing, and different people have different perspectives, but if you stay together and you stick with it, then you can actually make some progress, and you all understand that. I think we have a lot of lifers in the system. We have people who have seen, as their own professional capacity has grown and their competence, and they've seen the system, they actually, if they're sticking with it, they have a sense that this is something that they're committed to and that they believe is worthwhile sort of kind of fighting for. But to get back to your earlier point about, like giving people some resources where they're at. I know Stephen Lewis talked about this in his video about time being a critical resource.
Yeah.
We don't give people time. We don't give them even small pockets of money. We don't give them any kind of resources that would allow them to try some things, to innovate, to do some small tests of change. And when you have that mentality that there is, well, first of all, somebody else is controlling the budget, and that it's not an abundance mentality. It's not that we have all these resources. What would be the best way to use them? It's I don't have enough, and I'm going to keep mine, and
can't share.
Yeah, can't share. That we actually we are not, again, going back to the 40,000 people. We're not creating an opportunity for these leaders to emerge wherever they are and to be supported and to actually create the change. It's not going to be, I don't know, the 10 VPs or however many VPs there are now that are going to lead this, the kind of change that people want. I think another resource we don't use well when we're thinking about change in the system is our public. And in 2012, when we were doing, we did a national expert commission on the sustainability of the Canadian healthcare system and the health of Canadians. We had Nick Nanas do polling for us with public right across Canada. It blew me away, the willingness of people, and these are not people accessing the healthcare system necessarily, it was, just the public, their willingness to support the sustainability of the system. They were happy to pay their tax dollars for a system that didn't have waste and that was well functioning. And their willingness to donate their own time to be part of that restructuring. We have a huge public. We've got the baby boomers like me, but we've got another really well-educated public that could be part of it. But instead, we somehow believe that there's going to be this small group of people at the top of some system who are going to be able to figure out all the changes that need to be made. And if they're not on the Gemba, if they're not listening to people, if they're not providing time and resources for people who do have some good ideas and that would be able to make some changes that could be, spread more widely, then we are losing so much potential, so much creativity, so much, we've got wonderful thinkers. And doers, actually, and why aren't we using them? It's not just the health system. Dan, you could speak to education system, but somehow the health system has kept this structure that is
so oppressive. It's so oppressive. Yeah.
And it's built on, its origins of the colonialism that created it in the first place. And anyway, we have a lot of work to do on that, but we have a lot of resources if we would mobilize them and if we would get people the kinds of things that they need. I mean, time, I think Stephen says, like, we think if people are not working 120%, if nurses aren't going flat out on their unit, then we don't need as many of them. I witnessed this. I chair the independent assessment committees, and I witnessed that sort of thinking all of the time. If you gave that staff on that unit 10% of their time for actually learning and development and making changes, they would do it.
Yeah.
You wouldn't have to think about what you have to do. They could figure it out because they know the practice.
Yeah.
Interesting. That's great. I summed it up yesterday. I was kind of on a bit of a rant in a class.
Dan on a rant?
Yeah, I know. It happens. But I said, what the problem is? And I just blurted it out. I thought it was going to break out in song. It's industrial disease. Dire straits.
Yes.
Like we've got this old model. The military have abandoned it because it doesn't work, but we're still embracing, right? This old structure. And then we build bigger because, obviously bigger is better, right? It's a recognition that when someone comes to us to work, to contribute, to lead, to be able to practice, they don't work for this big monolith. They work for their unit. They work with a team. It's local. While we can talk about public health and broader community-based services, which are really important, care itself is delivered locally. It's, if you can't touch or virtually touch, you got a problem. So here's the tension. Here's my first reaction when I heard this notion of gaming, a gaming theory with finite and infinite. It's not either or, it's both. We're going to have to live with the reality.
Yeah.
And I think this is, Marlene, I don't know if you'll agree, but I think the use of driver diagrams gives us an opportunity to fit in the finite within the infinite game. Often what I've said to leaders is you'll hear it's all about the outcomes. And the problem with that is process is at least as important as the outcomes.
Yeah.
Because if I get outcomes and I've just burnt out all the staff, wrung out all the assets, left the place in a shambles, we survived a pandemic, or we achieved surgical waitlist nirvana. But the bottom line is, what's the capacity that we built within the organization to take on the next series?
That's right.
Because it never ends. It's continuous, right? The next series. So driver diagrams, I think, are key.
Okay.
So in education, this was a major aha for me as the privilege of serving as Deputy Minister of Education. Teachers said, based on the evidence, grade 3 literacy is the best determinant of graduation. So we were able to keep our eye on the ball in terms of educational attainment. And it was evolving and growing what that meant. Not just marks, not just a pass, but bringing out the full potential in people. At the same time, we were able to throw together a very important finite set of targets that got us, in some way, a controlled burn to be able to see the change, to celebrate the change, to be able to have the politicians witness during their political term an improvement, right? There are all kinds of issues we could share. We don't have enough time to do that, but I think the winning formula is somewhere in there. So when we talk about population health targets, these are by definition decades, right?
Yeah.
How do you get a political cycle of 4 years to line up with a 20-year initiative? And the answer is a driver diagram, leading and lagging measures, being able to show the picture and make sure that we continue to show the picture so we don't lose sight that it's not about this individual target or this individual initiative. It's about the greater mission.
And it's not just politicians who need that. That's brilliant, the way that you've described that, because we all, that's one of the Kouzes and Posner's attributes of good leadership, is to plan and celebrate small wins. That's what keeps people going.
Sure.
And what made my heart burst with pride was when I was with RQHR and I would go to the nursing units where they had, through their visibility wall, identified things that they were going to work on. And when they would come to their huddle, and then they would be so proud about, they had no falls on their falls cross, and the things that they had done to accomplish that is what keeps you going. But that was because they had the data that they needed at their level, and they were able to implement. And they actually, even at the time for a huddle, I don't know, 3 minutes or whatever it was, it valued them gathering. You didn't have to be out with patients every minute of your day or doing charting. You actually gathered and talked about how are we going to make this unit and this patient care better. So
you said something yesterday, Marlene, about transparency.
Yes.
I think the other element is those walls, that data was all there for the public and for the staff. Yeah, that was another important element.
Like, now we're recognizing, yes, we have to be this and we have to be this, and we have to see the system and we have to focus on local. I would think that would feel very overwhelming to leaders who are trying to lead in this increasing complexity, and there's more education than ever, and there's more thinking than ever, and there's more books than ever about all these different approaches and things. What if you guys could boil it down? What do you think are the key things that leaders need at every level that will help us shift out of this command and control, or at least have a little bit of balance between, the things we do have to command and control and the things that we maybe can let go of
Yeah.
and trust. Like Stephen has an article where he says, trust the talent, like such an educated workforce,
Right.
so many ideas, and yet we control it probably more than any other workforce out there.
Yeah.
So respect,
Yeah.
curiosity,
Mm-hmm.
Yeah.
humility, being present. Like, I don't care how big you are, go out there and see, right?
Mhm.
Go to where the problems are, speak to people, placing yourself out there in risking that somebody might ask you a question you don't have an answer to. Well, in command control, maybe that matters, but in this new era, it doesn't matter if you don't have the answers. It's about the questions,
Right.
about the learning. So these are easier said than done. And, we now have this other big elephant in the room, and that is government intervention
Mm.
directly into the health system. You
Mhm.
see, as we're struggling, we're being held more and more to account. And accountability in government is wholly different than accountability for learning that we're talking.
Right. Yes. Yes.
So we've got to become a bit of a buffer. We've got to be able to feed the need for information and data. We've got to build trust. I would say respect for people is probably number one on our list.
Mhm. Mhm.
Engagement of those in the know,
Yeah.
Mhm.
number one, number two on our list.
Mm.
Sorry,
I
Marlene,
No, I agree with all of those things. And I guess I was thinking about, what do I say to people who are in leadership roles or who are developing leadership? And there's a couple of key messages I give. One is, you are never there as a leader. If you think that you've learned everything you need to be about being a leader, you're wrong, because
Mhm.
leadership, like anything else, has to continually be developed, and you have to respond to the context and the environment that you're in. So I always say, create a leadership development plan for yourself. Like, you actually need to be that concrete. Use a framework, whatever framework you like, whatever theory, but every day you need to reflect on, how have I advanced my competence and my attributes in this area? And that, like I said, that for me is how I started to really think about, I have a responsibility to challenge the process. This isn't about somebody else doing it. I have, and how can I do that in a way that is respectful and garners trust and that kind of thing. I think the other thing is ongoing learning. And Kyla, you're well read and you spend a lot of time in the literature, but there are so many helpful resources. And if we can encourage our leaders to access the kinds of resources that they need, which might be literature and formal education, but sometimes it's peers and peer support. Or some of the units do things like have journal clubs or something like that, where
Yeah.
you actually get together and learn. I mean, I'm a teacher, so it's like, if I'm a hammer, everything looks like a nail. But I actually think that there's so much to be said about supporting people in their leadership development by actually continuing to learn. And Dan, you've said that many times. I actually think leadership is a very lonely job. It doesn't
Yes.
matter what your position is. So for sure you need mentors, and for sure you need a peer support group. I don't care if it's, if you're the director and you need other directors, but they need to seek that out and develop it themselves. But we actually, again, need to create time and space for that to occur. So
Yeah.
instead of rushing in and rushing out of meetings where the agenda is 10 times longer than what you can actually accomplish, and that you actually create other fora for people to come together and to do that. Dan said it. It's the Zoom sessions that we have are a bit of a therapy session for these people who don't
Yeah.
necessarily work together at all, but they have a chance to exchange some ideas and to reflect on oh, you're doing this, and how about this? Like 1 hour a week, and they show up, and they're busy people, but they show up because it's important to be able to talk to other people. We can structure some things to support leadership, ongoing leadership development in our system, in a way that demonstrates that it's valued. I don't think we've done a good job of that.
It's interesting because when you talk about the 1 hour a week, that and they're multidisciplinary and they're across all
Yeah.
kinds of
Yeah.
sectors,
All over
even
the
other
place. Yeah.
provinces, they never get that opportunity. So we
Yeah.
talk a good talk about working across silos, but they never actually get to meet to just talk, just chat. I think
Yeah.
if I were ever to become a CEO again, which probably isn't going to happen, I would start those types of forums. You talk about free time. We're going to
Yeah.
spend an hour. Anyone who wants to come forward, and we're just going to chat. We're going to innovate. We're going to think through and ask questions.
Yeah.
Somebody
So
asked me if I was interested in doing some coaching with doctors, and they asked
yeah,
if I had any experience in working with doctors, and I was like, yeah, I've had experience working, because he's like, they're real difficult. Like it's really hard to coach and work with them. And I said, oh, that's okay. I'm like, I've realized now after a few years of consulting that I just need a budget for beer and nachos. But honestly, that's a lot of what it is just
Yeah. Yeah.
talking and networking and building relationships and earning trust. And like, it's not as hard as I think people think it is.
that kind of it's interesting that as a relatively new grandfather, as a
Oh,
grandparent,
good. Yeah.
right?
Yeah.
My daughter asked me the other day, who are you? Because she doesn't recognize me, right?
Mhm.
Um, I have a feeling that if I ever ended up back in some role, people would look at me and say, I don't even recognize you. Like, who are you?
Yeah. Yeah.
And this
Yeah.
is back to Marlene's continuous learning. I mean, fundamentally at the core, we're the same people, but this is a journey. I mean,
Yes.
the learnings,
Yeah.
10 years I've been out, the learnings have been so steep.
Yeah.
And we look at it and we say, wow, if I only knew then what I know now. I'm in awe. Like, yes, we listen to people and we take the time to really hear their perspective. We mentioned yesterday's session because it was top of mind,
Mm-hmm.
but I'm in awe of what I heard
Mm-hmm.
yesterday,
Mm-hmm.
thinking, from those willing to kind of put it out there.
Yeah.
I think we have the nuggets. So I want to kind of leave a message of hope.
Mm-hmm.
There's
Yeah.
huge hope.
Yeah.
We've got people bursting to
Yeah.
want to participate. All they need is an invitation.
Yeah.
Um, Give them a North Star, and they will innovate around that North Star.
And along that line, I also want to give a message of hope and commendation, because as many times as we talk about, maybe the structural problems and people don't see it as a system and all that, the care at the clinical level is exceptional. And I have lots of opportunity. I've just journeyed with my sister through palliative care. I've my husband accesses healthcare system, my kids and grandkids. Like, I am blown away by how much I think it's improved. Patient and family centeredness, no question. Like,
Yeah.
you come on in, you're part of how can we work together with you? That wasn't the case probably even 20 years ago or 10 years ago. So I think there's been so much progress made in terms of
Mm.
what I would call the quality of care. I would give a lot of credit to the focus on quality improvement and that ability for people to kind of have permission to keep improving and making things better at whatever level they're at. And so it's definitely not all negative. And I just actually talked to two neighbors recently because they know I'm a retired nurse, and they said to me, I don't know what all the complaining is about. I got the best care ever. I couldn't have asked for anything more. And I say, kudos to you and to the system
Yes.
and to the
Yeah.
people in the system that do it. So there's lots of room for hope and positivity and optimism. But if in the thinking of always wanting to make the system better, we have to keep challenging it. We have to keep asking questions about it and making sure that we're going to be responsive, not just for the people of today, but for the people of tomorrow and 10 and 15 years from today. So anyway, that would be I think you're right, Dan, to say we have to leave with hope, because we do have that benefit of interacting with people who are in the system and who are doing brilliant things.
So it's interesting that two things can be true at the same time. We
Yeah.
need
Right.
lots of improvement on the
Yeah.
administrative side, on the logistical side, in terms of dealing with quality and safety. There's still a long journey ahead of us,
Yeah.
but we have the ability to do things that are just second to none.
Well,
Really
and
impressive.
even this morning, my mom went to the doctor a few days ago and she needs a follow-up. And we said, well, do you have that follow-up booked? And she's with a primary care team in Swift Current. And she said, no, because I know I can get a same-day appointment because
That's
they've
right.
restructured to team-based care. And
Yeah.
I was like, Wow, that's a change. That's an improvement, right? Like
Exactly.
we're
Heather, do you remember the work on positive deviance? You know,
yes.
in spite of any problem that we're
Yes.
dealing with, someone somewhere has
Yes.
succeeded. And
Yes.
Marlene, your work internationally, I mean, this was the heart of it. You go and you look with the community, given all the same constraints, there's always someone who's thriving.
Yep.
And you
Yep.
ask, well, what is it about them?
Yeah.
Maybe
Yeah.
that's the work we need to start shifting into. Like
Yeah.
shine a spotlight on what's
Yeah.
going really great and
Yeah.
then understand, okay, so why can't we have this everywhere? It's that kind of elusive scale and spread that the Canadian system has really struggled at. We got really
Yes.
good at that, right?
Yeah, that's right.
Be
And that's
massive.
the conversations I'm trying to have on this podcast. Like,
Yeah.
where are people pushing through? Where are they making changes? And then highlighting it so that other people can say, oh, maybe we could do that here.
Yeah.
Or, well, I don't know why they're doing it and the town over is not doing it. Like, what's the holdup? So that's my goal, is to find all the individuals, the teams, the organizations, the communities that are just taking a risk and doing things differently and it's working, and then come tell me about it, come share it with other people, and then that'll maybe inspire other people to learn from them and then do the same thing, because
Well,
we
you
do
recall
not
with,
share enough in this system.
yeah, you recall with releasing time to care.
Mhm.
The real innovation was in the collaborative, right? In
Yes.
bringing people together and
Yes.
oh my
Yes.
God, they're sharing and here's
Yeah.
what worked, here's what didn't work. I
Yes.
mean, that's what we need to do is
Yeah.
to get that cascade of learning where we
Yes.
can say this is possible.
Yeah. Yeah. Releasing Time to Care was probably the most, affecting program that I ever did, in terms of seeing the potential of what happens when you give people space, time, a little bit of resources, and permission to just do things. And they were, in a lot of cases, small things that made a huge difference. Like you were saying, Dan, like I would like to get some of that energy back to the
We
front
need to.
line. Yeah. I
So
don't
why
know
don't we?
how.
Well,
Yeah.
the good news, Kylie, is when I was in Yorkton in the fall, I can't remember. I was it was part of an IAC site visit, and the nurses on the unit actually talked about releasing time to care.
Mhm. Yeah, it
That's
still comes up.
20 years ago, and
Yeah.
they talked about the things that some of them had been there that long, and they talked about the things they implemented. So I think the mindset that comes along with that, those sorts of programs, will stick with people. Again, if we just get things out, the barriers out of the way, so that they can actually do what they know they need to do, we'll release tons of potential.
So building on that, I would say let's get back to the unit.
Mhm.
And again, running the risk that there's going to be a lot of point improvement, but that's
Yeah.
okay.
Yeah.
That's okay. We need to
Build
really
on it.
build on what makes for a
Mhm.
great day,
Mhm.
right? Build
Yeah.
on.
Yeah.
Yeah.
The next level is the design of a new RTC, a
Mhm.
series of modules that look at the patient journey
Yeah.
Mhm.
across sectors. And then the next level is to look across in an intersectoral way at
Mm.
how we can collaborate to influence the social determinants of health.
Mm.
So we've got a capability here of doing something that's breakthrough. And it's not everything, but it's a huge way of flipping a culture by changing our behaviors and actions. You mentioned it was difficult in the RTC days to get a leader to visit
Yeah.
a unit.
Yeah.
That's got to be something that's every day.
Yeah.
Yeah.
And it doesn't matter how big, go somewhere, go anywhere,
Yeah.
but go there with intent.
Mhm.
Go there, not just management by walking around, but
Mm.
curiosity
Mhm.
Yep.
around what they're doing and celebration in
Mhm.
terms of shining a spotlight on the great things that are going on.
Well, I know you guys have meetings coming up, so I'll let you go. Thank you so much for taking the time. I know that this conversation, again, will inspire people, will make people think, maybe, and maybe even take your program, which would be
Be
amazing.
awesome.
Yeah, awesome.
Yeah.